Welcome again, and thank you for joining. This is Pediatric Feeding Disorder Resource webinar, and we are meeting today to go over a new resource that will be available soon, and we want you to get a chance to preview it before it comes out so you know what to expect. Today's session, again, is recorded, so please save questions until the end or enter them into the chat. And with that, we'll get started today. I wanted to share that we began the process of developing support from DPI for the area of feeding and swallowing in the schools in the spring of 2023. So we brought together a group of interdisciplinary experts in the field, and this led to the series of webinars that we held this past school year on pediatric feeding disorders, or PFD. You can still access the recorded webinars through the link that you see on this slide, and it includes the videos and handouts from the series. And PFD is an area I always wanted more information on when I was working in the schools as a speech-language pathologist. So when I became the education consultant for speech and language at DPI, I was provided the opportunity to pursue this project. So I really want to thank members of the Feeding and Swallowing Work Group for getting us to the point we are at today. And that includes Amy Delaney and Jennifer Eggert from Marquette University. We had Carlin Higby and Michelle Silverman, DPI OT and PT consultants, as part of our group. We had Louise Wilson, DPI school nurse consultant, Margaret Pandel and Michelle Zvanar, DPI school nutrition team. And then we also had Ann Berry, speech language pathologist from Racine School District, as part of our group. So the resource we're sharing with you today was created to support your work with pediatric feeding disorders in the schools and will be available soon. But prior to the publication, as I mentioned, we wanted to provide you a sneak peek into the resource so you know what to expect when it is available. A couple of additional acknowledgments and thank yous also go out to the Arkansas Department of Education for sharing their guide as a model for this project, along with Emily Homer, who established a step-by-step procedure for addressing swallowing and feeding in the schools. And she also led the educational series and guidebook development in the state of Arkansas. So we had a really nice model to follow. And then we were able to put our own information in from the perspective of Wisconsin. Finally, I really want to thank Jennifer Eggert, who will join me in introducing the resource in a few moments. Jennifer led the webinar series for Wisconsin DPI that we held this past school year and really helped to support the development of this resource. Just a couple reminders before diving into the resource. We want to remind you that school teams are not medical teams, so it is not expected that you will become specialists in pediatric feeding disorders. The number one best practice consideration is to develop enough expertise to ensure student participation and safety in schools. So this means that we recognize what's outside of our current skill set or the skill set of the IEP team. We collaborate with medical team members when available, and we possibly contract out for services when that's indicated. And school teams in Wisconsin primarily focus on collaboration and implementation of safe feeding and swallowing procedures, rather than providing direct therapeutic intervention. And you'll see more about that as we dive into the guidebook. And as always, you are welcome to reach out to myself and Jennifer if you have any additional questions after this webinar and any other questions from the series. So with that, I will switch screens and we'll dive into this incredible new resource.
Dawn, while you're switching screens, I will reintroduce myself. My name is Jen Eggert. I am a clinical assistant professor at Marquette University, and I do not have a voice disorder. I have a very bad cold. So for those of you who may be hearing me for the first time, this is not what I typically sound like. And for those of you who have heard me before, I haven't been jamming out at any concerts or anything and doing any vocal abuse. But I'm super excited to be here today, comfy and cozy from my old home. I may switch over to Dawn as needed if I have a little tickle in my nose or tickle in my throat, but we're going to power through this because gosh darn it, we have worked so hard to get this resource put together. And it has been truly a highlight of the last several years for me to not only be part of this team, but to be part of putting this resource together, to be part of leading all of these webinars, and also collaborating with Feeding Matters, which is an amazing organization, on putting together, myself and the advocacy pillar chair, a resource that is available called the ARFID and PFD Toolkit. And so that's a great additional resource that has recently come out. And so again, just for those of you who may not have met me before, to know that although I am in higher ed, I do have a ton of pediatric experience, and in addition to a little bit of time playing in the school systems, and really am tied into this group. So speaking to you from a passionate personal experience, and I'm really excited to get this guidebook shared with all of you today. So Dawn has her screen up and ready to go, and she's going to talk to us just a little bit about introduction of the guidebook here, and then I'll hop back in and we'll talk some more about the specifics on each of the pages.
Thanks, Jen. And so glad that you're still able to join us today, although I feel rocking out at a concert would be more fun than dealing with the cold right now, but happy that you're here and continuing to support this work. So what you see here is what the resource will look like in public once it's published. And it's going to have a cover sheet that lets you know that it's a resource for supporting pediatric feeding disorders in Wisconsin. You will see a foreword from our state superintendent, Jill Underly, some acknowledgments and thank yous, which we just talked about on the previous slides. And then we'll talk about the purpose of the resource. So as I mentioned earlier, that safe feeding and swallowing are really critical to providing adequate nutrition and life-sustaining activities. So we want to keep all children safe and ready to learn. And so we really want to use this document to provide education professionals with a resource to help meet the needs of students with pediatric feeding disorders within educational settings in Wisconsin. We utilize a team approach. We utilize the team approach in planning, and we recommend continued team approach as you are working in the schools. So the intention of this resource is to really help facilitate that student participation in safe feeding and swallowing in schools. You will find the table of contents, which will be linked to each section. And so the first section, which we'll look at in just a little bit, has general information on what pediatric feeding disorders involves. So you will see some information about diagnostic criteria, phases of swallowing, prevalence, things like that. Section 2 looks at foundations for addressing pediatric feeding disorders within the school setting. And so we're going to talk about the rationale for doing this, administrative support and the importance of that, a step-by-step process that will probably be your key area that you'll focus on as you use this guide, and then the interdisciplinary team approach. And that leads us into the forms. So we'll talk about how students eat safely in Wisconsin and following the forms, and talk about each area from referral all the way through development of that safe eating plan and implementation of that. We do have a section related to childcare and preschool procedures because our littles coming into school may eat or do things a little differently than most of our school-age children. So just some considerations there. Some training considerations for the core team and some strategies that can add confidence if you are not feeling confident yet in this area. And then section 6 looks at school services for pediatric feeding disorders, just some other things to consider, looking at the different phases of dysphagia, some safe feeding considerations, some other factors such as psychosocial factors of feeding. And then at the end, we have our references, worksheets, and an appendix. So all of the worksheets and checklists are at the end of the document, and they're there for your use. You will also see that we have a case study as part of this document, and you'll see a reference back to the case study as we go throughout. And then that brings us into section 1, that general information on pediatric feeding. And I will turn it over to Jen to kind of talk just briefly through the diagnostic criteria.
Thank you, Dawn. Just by a show of emojis, if it's safe for you at this moment, I'm curious, how many of you are here for the first time? If you're here for the first time, go ahead and give me a thumbs up. If you are returning, throw up a heart in that chat. Just out of curiosity, we'd love to know if you're new to us or if you're returning to us. Oh, I'm seeing so many thumbs up. That is so exciting to me that you are here for the launch of this. And I see it in the chat and I see them floating all over my screen. Again, I want to reassure you, because there are so many thumbs flying everywhere, I want to reassure you that our goal with this is not to make you an expert in feeding and swallowing. As school speech pathologists, you are amazing at working within the 9 big areas of practice that we work in, and are so inclusive of the many, many students that you work with. And it is a lot of work. We want to recognize it. It is a lot of work. And so in saying that in the opening, Dawn was again reassuring you that this is meant to guide you, and this is meant to give you all the information that you need to be able to understand this unique subset of children. So in going through the guidebook here, we are on page 9. Pediatric feeding disorder is defined by the World Health Organization's International Classification of Functioning and Disability as impaired oral intake that is not age appropriate and is associated with medical dysfunction, nutritional dysfunction, feeding skill dysfunction, and psychosocial dysfunction. And so this diagnostic criteria of being a disturbance in oral intake of nutrients appropriate, again, for their chronological age versus their developmental age, is a really important and salient piece that we want to start with. This is a diagnostic criteria that lasts for at least 2 weeks and associated with one of the more following areas. So we have 4 subdomains as shown in this amazing diagram here from Feeding Matters. The first is the medical dysfunction domain. So for example, a child who may have a cardiorespiratory compromise during oral feeding, aspiration or recurrent aspiration pneumonia. We have the nutritional dysfunction domain, which is truly malnutrition. And that should cause us all to pause and think again about how important the work is that you are all doing in providing safe and functional carryover of this within the schools. We can also see, and we see this a lot within our autism spectrum, or individuals who are autistic. We use both terms interchangeably, in that they may have specific nutrient deficiencies or significant restricted intake in one or more of the nutrients, resulting from decreased dietary diversity. We all know those kids who eat all of the what we call the brown or the white foods, right? The crackers, the chicken nuggets, the French fries. And then we have individuals who, for a variety of reasons, may have a reliance on enteral feeds or oral supplements to sustain nutrition or hydration. That leads us to our third domain, which is the feeding skill dysfunction. To clarify that, really that sort of splits into 2 subsections. One being those individuals who have a true oral motor deficiency. And so they may have a need for textured modification of liquid or food. They may need modified feeding position or equipment. They may need the use of modified feeding strategies. In addition, all of these same things apply to those students who may have a more a feeding domain, a feeding skill dysfunction domain that is more based on the oral sensory components of eating. So oral motor versus oral sensory. And then fourthly, we have the psychosocial dysfunction domain, which is the active or passive avoidance of behaviors by a child when feeding or being fed. There could be inappropriate caregiver management of child's feeding and nutrition needs. We do have individuals who, because they care so much for that child and they know that they have to get those nutrients in, they have been force feeding the child or setting up situations where there is an expectation that the child eats. We may see disruption of social functioning within a feeding context and disruption of that caregiver-child relationship associated with feeding. So these symptoms are, again, considered acute if it's less than 3 months, or chronic if it's more than 3 months. We're going to go ahead and skip here over some of the phases of swallowing. That's something that you can review for yourself, and some of the statistics related to this. But we do want to spend just a moment here on page 13 reviewing the signs and symptoms of pediatric feeding disorder, or PFD, by domain. And this is really the red flags. What are we looking for? Again, this is a team approach. It's not just you, it's also the paraprofessionals, the special ed and regular ed teachers, OT, PT, anybody who's interacting with those children. So from a medical domain, we may see individuals who have chronic respiratory concerns or acute illnesses such as pneumonia, coughing or choking during or after swallowing, drooling, poor oral motor functioning, which can lead to, again, some of those medical concerns. Any wet or gurgly airway soundings, or holding food and difficulty initiating that swallow. From a nutrition standpoint, we see children who are unable to eat or drink enough to grow or stay hydrated, or inefficient or too rapid of a change in weight or height. We do see kids who have tube feedings that are sometimes not as well managed as they should be, and they gain too much weight, and that can be really challenging for them to get under control. Again, we see those individuals who have, those students who have that lack of certain nutrients, reliance on particular foods for nutrition, and or the need for enteral feeds for nutrition. When I went into speech therapy and started specializing in feeding and swallowing, I did not realize how much time I'd spend talking about what comes out of the body. We spend so much time focusing on what goes into the body, but constipation is a huge issue for our kids. In the feeding skill domain, we see students who have this need for special preparation of texture. They may be unable to self-feed. This is where our amazing OTs come in. They may have extremely short or long meal times. We see the need for specialized equipment and positioning, again, where those OTs and PTs, our team players, come in, and specialized strategies to eat, stuffing or holding of food or difficulty with chewing. And then in the psychosocial domain, we look at the refusal to eat, all foods, food presented with others in certain situations, individuals, whether it be the participant or the student themselves or the caregiver who appears stressed, worried, feel fearful during meal times, and behavioral challenges resulting in unpleasant meal times, such as disruptive behaviors or the need to bribe or coerce or distract a child. This can also include those children who, and it overlaps into their sensory needs, need to get up and constantly move from the table. And we want to respect that, but also help to shape that into a safe environment where they can participate in mealtime more fully. With that, I'm going to hand it back over to Dawn, who's going to talk a little bit about the rationale.
Okay, so we're going to skip ahead a couple of slides here, or a couple of pages. And so the rationale for developing this guidance, number one is student safety. Schools have an obligation to provide a safe environment for students while they're at school, including during meal times. So that is number one there. Federal laws also dictate our reasoning for being involved in feeding and swallowing in schools. Both IDEA and Section 504 regulations require a free, appropriate public education, or FAPE, for students with disabilities, and meeting health needs is required when determined necessary for FAPE. There are case law implications, several Supreme Court and state cases that support the responsibility of school districts to provide health services for students to stay in school and access their curriculum. And there are federal regulations related to food service and nutrition in schools. There's also our code of ethics, our professional code of ethics, which talks about our roles and responsibilities. And if you look back to some of the webinars previously, we really outlined the roles and responsibilities of each of the team members, but also mentioned that code of ethics here. And with that, I'm going to jump ahead to the steps.
So in thinking about the steps to looking at the PFD procedures within the school system, it is going to look somewhat and very similar to the steps of a typical IEP or referral process. We want to highlight, though, some places where there are pieces where we want to take more action related to the health components of these students. So we're going to start, as we always do, with a referral and a review of existing information. That review of existing information may look somewhat different. There may be a lot of medical information in that review of existing information, especially from our colleagues out in the field please, please, please become friends, become a contact with any speech pathologists who work in medical settings, pediatric medical, outpatient, or hospitals in your community. They want to partner with you. They just don't know who you are. So if you get a report from them, give them a call. If you need help interpreting that report, ask them, or you know what, the nurses that you work with are amazing at being able to help interpret this. And they also are really used to making those phone calls to doctors' offices, to clinics. So that takes us into that step number 3, which is contacting healthcare providers. We then go into a comprehensive special education evaluation, as we always do, and develop an IEP, at which point we then pivot to establish a safe eating plan and a cafeteria procedure and school personnel training. That training of school personnel is vital to the safety and participation of these students. When Dawn and I started working on this together, one of the points that I returned to again and again was that while I want to partner and we need to partner with our speech pathologists, our occupational therapists, etc., we really need to pull in our paraprofessionals and our educational assistants. They are with those students more than we are, and they really know them very well. They are such an important part of our team. We want to, as we always do some progress monitoring, but that may look a little bit different, especially since, again, we are looking at possibly intake and volume and times, and as needed, whenever we have to, revise that safe eating plan. That can come up because of a change in a child's medical status. That could come up because of progress. I think we forget that sometimes, that we think, oh, we have to change something because the child had a medical procedure. But sometimes those medical procedures in and of themselves can result in progress. For example, say there was a lip revision or palate revision for a child with a cleft lip or palate. So these steps should look somewhat familiar to you and aren't completely unfamiliar, but there's a few extra pieces in there. We're now going to look at foundation number 4, which is this interdisciplinary team approach, which I've already alluded to. We know that collaborating as a team is essential, and it is especially essential when providing PFD services in the schools. A team approach is most effective when all members know the procedures for supporting students with feeding and swallowing concerns, are aware of each other's roles, and can participate in what we call role release. We'll talk about that a little bit, and collaborate and share information with other team members. Each district will have a unique composition of availability and resources. You are all unique. Therefore, team structure will vary from school to school. Yet, despite this variability, the following professionals are recommended to form a core team, and those team members should all look familiar to you because we've talked about them all already today. In terms of the roles and responsibilities, we look at, again, each team member bringing their own level of knowledge and expertise, and the district and the individual professionals being responsible for increasing their knowledge and skills in swallowing and feeding as needed. Because all team members of the PFD team are responsible for referring students who are at risk, supporting students with PFD, ensuring the safety of students at school, including their participation, and educating school personnel and families. We suggest that each team has a team leader who is a person designated to oversee this process, and want to recognize again that various professionals could serve as the team leader on their level of training and expertise. When dysphagia is a primary concern, the role is often filled by the SLP. But when concerns primarily are related to self-feeding or sensory, perhaps the OT is the team leader. For a child who has medical fragility or medical involvement, we may see the school nurse function in this role. Moving on here to page 22, we have broken down for you the potential, again, I want to highlight potential roles and responsibilities. We want to reassure you that each team member is unique. I will say it again and again, and if you listen to recordings, you will hear me. I sound like a broken record. We are not expecting you to become experts in feeding and swallowing. But we do see that speech language pathologists often do serve in the role of the PFD team leader. They may be the ones to initially identify students at risk and coordinate the assessments. If possible, if your district can allow it, attending the video fluoroscopic swallow study or the swallow study can be vital to your understanding and again to that student's participation in the school district. You may be responsible for training teachers and other individuals, collaborating with those individuals to ensure their safety, and maintaining and obtaining the appropriate training to address PFD. Maybe this is something that you're really interested in, and your district is like, hey, you know what? We have this small little fund. We have some time for you. We would like you to get a little more training in this. If you're interested in that, reach out to me. I have tons of resources that I would love to share with you. Some of these are going to overlap, as we see with the occupational therapist. Again, everybody's going to attend an IEP meeting when indicated and ensure that the student health plan or emergency plan of action is easily accessible. The important role of the OTs may be to be the person designated as a feeder in any adaptation tools or sensory adaptations. Again, helping to develop the oral motor, oral sensory, or behavioral plans that are needed, and to provide therapy. We're going to skip ahead here to page 23 because we have a lot to cover, and you can read these. The PTs are great at helping us with postural stability, making sure that individuals have the positioning and the equipment that they need. And our school nurses, as we have already talked about, are really important at monitoring our student health within the school day. Writing student health plans or emergency action plans, training everyone on the emergency plan for choking, assisting in contacting physicians as related to medical diagnoses, and consulting with parents and teachers. You know, we again recognize how busy you all are. We recognize caseload numbers. And school nurses are busy too, but sometimes they do have time built into their day to build to make a phone call, to send an email. And so please partner with them. They are medical information specialists. As we're going through this, I want to remind everybody that this is not yet published. It's going through the final stages of that and will be available soon. So you are all part of a sneak peek. And as soon as it is published, Dawn will be sending you all many, many emails about it. In terms of the school personnel and their roles and responsibilities, we should look at, again, the regular and special ed teachers, paraprofessionals, or educational assistants. Any other person who is in a daily contact with that child is going to be a wealth of knowledge. They will be very, very important in telling us, what does this child do throughout the day? They see the child in a bigger picture. We see them in snapshots. Same with the school cafeteria manager and the principal. Please, please bring in your administrative personnel into this process. It is for everybody's best interest, that they are aware of these students, that they are learning about these students, and most importantly, that they are supporting you in supporting these students. Last and definitely not least are the parents or caregivers. They are experts in their children. We are experts in all of our own fields, but they are experts in their children. And so they will be able to share knowledge of children's feeding habits, food preferences, and mealtime environment with you. Provide a demonstration of safe feeding procedures for school staff. It is vital that you ask them to show you how that child eats, how they feed that child. That may even mean using all of the amazing technology we have. Maybe you set up some sort of a meeting with them virtually so that you can watch them do it at home. Maybe you ask them to videotape something and send it to you. We have so many options these days to get that information. Equally as important in participating in that decision making regarding school meal times is that they share cultural views as it pertains to food choices, habits, perceptions of disabilities, and beliefs about intervention. Do not overlook the fact that you will have children on your caseload who are old enough to participate in this, who are cognitively intact enough to participate in this, and they should also be part of making those decisions. All right, so moving on, we're going to look at page 33 here. We're going to skip through some of the examples of team models. This guidebook again then gets into some different worksheets, which again we have here all outlined for you and linked for you. Dawn worked with our company here to do an amazing job of all of that. But we do want to spend a little bit of time here looking at step 4 of the comprehensive special education evaluation, which is completing that interdisciplinary assessment. We lead perfectly into highlighting the importance of students and their caregivers in this process by, again, reminding ourselves that the caregiver and or student should be interviewed. We want to observe. We want to observe them in their typical eating environment, not only in the school, but at home. You would be shocked at some of the amazing things that parents instinctively do when they are trying to figure out how to support their child in participating in mealtime. I am always so impressed with parents. Again, I always say parents are experts in their children. And so observing them in their home, they may have some amazing setup that you're like, wow, I never thought about that. Or we have to find some similar equipment for them here at school. And then assessing the oral motor skills of the student. And again, you're like, I don't even know what I'm looking for. Well, we are going to give you plenty of resources to make sure that you know what you are looking for. Again, I want to remind you that the links to these sample forms are just that. They are sample forms. They are not a DPI requirement, but they should be part of an interdisciplinary process. Okay, here are some oral motor observations that you may be looking at. You can look through that. And then we look at the development of the IEP process, which you guys are all experts in. If we stop for a minute here on page 36 of this guidebook, we can look at the supplementary aids and services that may be included for our child, for our students, and what you may want to consider for these students. Adaptive equipment should be included. And that could be everything from a spoon to a chair that they need to sit in, to maybe they have a bowl that sticks to their tray so that they can self-feed. Extra time for eating. It may take some children longer to eat, and we want to give them that time without stressing them out that they have to hurry up to get their nutrition in. Opportunity to bring special foods from home for children with restricted diets, food allergies, or need for specific textures or consistencies. It is really a myth that does not do us any good when we think that the child only has to eat either what is brought from home or only what is served by the cafeteria. There is no reason why we have to stick to that. And there are many, many ways that we can work as a team to ensure that the child is getting a mixture of whatever they need. If a child wants to take the hot lunch, but they're only going to eat the chicken nuggets, you know what? You have the right to only have them eat the chicken nuggets. It's okay. Because maybe the creamed corn that is on that tray that day is going to cause them to gag. Maybe the smell of the broccoli on the tray that day is going to be enough that it will send them away from the one food that they would eat. Some of our students are going to need opportunities to snack during instruction or short breaks from instruction during the day for snacking. And again, thinking about our kids who need to consume sufficient calories during a longer period of time, and they may need to bring in some of those snacks themselves. We've had lots of school teams that have reached out to us that have gotten really great at working with their lunchroom team as far as getting access to blenders and microwaves and anything that they need to ensure that that child is eating anything and everything that they can in a way that is going to let them successfully eat. Familiar adults to provide supervision during eating. This is going to mean that we prepare for days when people are sick, just like me, right? We sometimes get illnesses and we cannot be there. So if Martha is usually the aide that is with that student, who's the backup to Martha? Who is the person that secondarily knows that child and can safely support them? Looking at visual verbal cues for chewing and swallowing, in addition to the appropriate bite size to prevent choking, in addition to monitoring how much food they have in their mouth. We have lots of friends who love to stuff and who will keep that piece of beef in their mouth until they go to bed and they brush their teeth and mom or dad finds it in there. Sometimes we need behavior motivators. Sometimes we need, again, all of those unique specific chairs or utensils, fidgets or sensory supports. Thinking about how does mealtime look? For example, a lunch bunch group, an adult supported peer group to provide modeling and socialization during meals and snacks. I think school districts get really nervous, like this child will not succeed in the lunchroom. And I say this child will not succeed in the lunchroom yet. And so it is thinking outside the box time, right? So what do kids love more than anything? They love to feel like they are special. They love to feel like they are a helper. So could we arrange that there's a rotation of kids that eat with that child in the classroom and start getting them used to the noises and the bumps and the pokes and the smells of lunch in doing so with their peers? We can do that. We have to support our kids. Here on page 37, we're looking at that safe eating plan. This safe eating plan is going to be different from the emergency health plan. We want to make sure that we differentiate those two. So the safe eating plan should be drafted based on the information gathered during this comprehensive special education evaluation and the development of the IEP. The plan should include information the school personnel will need in order to feed the students safely and efficiently. Any training that is needed on the safe eating plan should be included in the IEP under program modifications or supports for school personnel. This is where it has been just such a joy to work with Dawn, because while I may be an expert in feeding and swallowing, she's an expert on IEPs and all of these components. So if you have the feeding and swallowing questions, reach out to me. For any of those IEP questions, reach out to Dawn. You will see here a list of all of the things that the safe eating plan could include. We've talked about a lot of these already. So let's just compare this very briefly. Here we're going to go to page 38 to talk about the cafeteria procedures. Again, we have this safe eating plan, right? We have an emergency health plan, but also then we need some cafeteria plans. And this again is going to be the second component of the safe eating plan, which is the school personnel training. It is one of the most important roles of the team. It is recommended that 2 or 3 feeders be trained for every student. It is required that school personnel receive training on the safe eating plan before feeding the student. We do have a lot of children who have some unique feeding needs in terms of preferences, but I don't want us to forget that we have a lot of children who have very, very important feeding needs based upon their safety. The goal of this training is for designated feeders to follow the student's plan. And this school personnel training should be documented on the trade feeders worksheet, which we have there for you, an example of, and there should be periodic monitoring. You know what? We can all forget things. We all can get lazy and be like, oh, this is working just fine. And maybe there's a step, maybe there's a component that is really important. And so when you're looking at building your teams, not only do we need to trust each other in terms of role release to say, I know you can do this, but we also need to trust each other in terms of feedback and support to feel safe in our environment to say, I know you know this, and I know that this is what's important for the student's safety. Both can be true. Okay, I'm going to turn it over to Dawn here for a moment, and she's going to talk a little bit about the preschool versus school age service provision differences.
Okay, so really things might look just a little bit different when you're working with our preschool age population. So we wanted to make sure we included that section here. And just a reminder that this is for children 3 to 5. And what we included in this section were some different scenarios because our students may be receiving their services in different locations. And so based on whether it's at the school site, at a Head Start or similar location, or maybe at a preschool or community childcare site, there are some scenarios listed here for you to consider and things to think about when you're developing your plan. Then the next thing that we do talk about is how that works and how we can facilitate a smooth transition from early intervention to the public schools and how critical that is. We did a comparison. There was a comparison earlier of medical versus school services. Here we have a comparison that's similar to that, but looking at early intervention programming versus school-based programming. And so you'll be able to find that comparison within this document. And just remembering that we're setting the stage for a positive educational experience when we're working with our youngest students, and we're also working with their caregivers, especially at that age too, school personnel and administrators, so we can really have a nice transition for all. And then we get into building capacity for our educators. So Jen, I'll turn it back to you.
Okay, so we are looking here at page 51 of the guidance book, and building capacities. What helps to add to feeder confidence? As somebody who's worked with students and children with PFD for over 25 years, one of the things I can tell you is that something you probably already know is that students will know when you're nervous. Students can sense that. And so we want you to think about some things that you can do to help yourself. First of all, looking at this adorable little child here would certainly help me to feel more confident, because they are absolutely adorable and looking to me to be a partner in this. So partner with the child, set a goal for yourself. Each team member can set an individual goal and establish a plan for updating their skills. There are some tools here that we have for you that could be useful. If you find that you are looking for additional tools, you're looking for additional trainings, you're looking for webinars, seminars, whatnot, again, please feel free to reach out to me. Individual learning. We spend so much time reading current research, journal articles, and maybe attending lectures and webinars. Maybe we need to do a little bit of a shift and do some of that related to feeding and swallowing. Observing other professionals in your district who are experienced with identifying and treating PFD. If you are an individual who has time off during the summer, that could be a perfect time to contact, again, somebody in your community who you've partnered with and say, you know, I'd like to expand my skill set. Is there an opportunity for me to do some observation? I have learned, as somebody who works in higher ed, if I can teach it, I know it, right? So researching and preparing presentations for district therapists to teach them more about this. Buy a trusted dysphagia textbook that is currently used, and these can be great resources for you. Looking at professional development here, again, lots of professional development. The Astra Learning Pass is a great place. Go to Feeding Matters. It's simply feedingmatters.org. Feeding Matters is great because it has a ton of information and it has some free trainings on there. If you have difficulty finding those free trainings, let me know and I can link you to them. Access experienced school personnel and experts outside of the school. We've talked about this a little bit. Find a friend, right? And learn about each student with PFD on your caseload. Each of these students is going to present in a unique manner. And so you will need to, you will benefit from looking at their unique presentation. Looking ahead here on page 54, we want you to think about these considerations from several perspectives. From a medical perspective, we want to ensure, again, that the child is gaining weight and growing. Are there recommended experts from outside of the school or district that can be addressed in the school? We might need to pull in GI. Again, these are things that the nurse can help the family to coordinate. From a nutritional perspective, again, are there deficits in vitamins, minerals, entire food groups? And then from an educational perspective, which is where your expertise is the child able to attend school? Dawn, we have a question in the chat that I responded to that I said we would reply at the end, related to homebound students. And do we create a safe feeding plan for them? Does the child eat what their caregiver packs for them? And does that need to be modified? Is the child safe at school? Are they at risk of choking? Are there problems with attention during academic tasks? And that attention may go back to the nutrition or the medical perspective. Some really important considerations there. We're going to forward here to page 48. There are lots of tips and tricks here for you related to the beginning of the school year. Looking at oral phase dysphagia and safe feeding considerations, looking at pharyngeal phase dysphagia. We're going to go ahead and pause here and just think about, again, do we need to look at any of these safe feeding considerations for our students? And I'm just looking here, Dawn, at page 58 real quickly. We are then going to go ahead to page 61. And on page 61, we want to talk about the psychosocial factors. This is something that I think, first of all, I want to differentiate between ARFID, which I did not spell out for you, so that is my error. Avoidant restrictive food intake disorder, which is its own psychological domain and diagnosis. But what we know is many children with RFID also have PFD or had PFD, and many children with PFD also have RFID. So there's a lot of overlap. Again, there's great visuals on Feeding Matters, which can help you with that. But in general, that psychosocial domain can stand alone from students who have RFID. So these are children with PFD. And so we see that sometimes the psychosocial factor, this child has learned a response to foods or liquids, and it interferes with their ability to function normally in daily activities. And this can be so stressful for the families, and so stressful for the child too. So we can see children who have this oral defensiveness, oral hypersensitivity, picky eating, feeding aversion, food jags, where they eat only one thing. Remember, some of this is typical, right? The 2-year-old who only eats macaroni and cheese for a week and then hates it. But this could continue on. Limited eating, food refusal, vomiting, and gagging. What happens is, because these behaviors exhibit, because of these responses, true body responses, these psychosocial factors can begin to tie in. And so to successfully address the psychosocial factors, it's going to be necessary for you as a team to identify the underlying causes of the behaviors being observed at school. You should work with the caregivers and physicians to identify any medical issues. Perhaps there is a child who has some esophageal dysfunction. Say there is some significant reflux that's causing pain. And that is resulting in, again, some of these behaviors that we're seeing. So again, we want to make sure that we take time to pull this out, because it can seem as though children are just refusing or running away from meal times. But again, my thought is, what is the why behind it? Why are they doing this? Where did this come from, right? We say all the time, behavior is communication. All right. So Dawn's going to take us through these forms, these amazing forms that we've put together.
Right. And just to remind you, this entire document will soon be available and published for you to access. But if you want to use any of these forms that you're seeing now, if you go back to our series from the last school year, each series we connected you with documents, forms, assessment procedures, things like that. So you can certainly go back into all of the videos and handouts and find those there. And those are linked on the speech or language impairment website. It looks like this, where you can see all of the handouts from the series, all of the videos from the series. The handout from today is linked on this now, and I will also link the video from today in case you want to share it out within your district. And so these forms, again, are optional. These are not DPI required forms, but if you're looking for something to use, this might be a good place to start, and you're certainly welcome to develop your own forms in your district. So in this area, you will find an instrumental evaluation worksheet. This might be something that you would fill out with concerns that you have from the school system and that you would like to receive from the instrumental evaluation. This release to communicate also, and I'm sure that you have your own forms for release of information in your districts as well. There are sample forms for the caregiver interview, which was mentioned earlier. And so you will see that in the back part here, which goes into a lot of different details about how the child eats or is fed. There is an observation worksheet, so something you can use when you're observing that student eat. That is available. And then there's an interdisciplinary assessment worksheet. Jen mentioned that earlier, so that you can complete the evaluation itself collaboratively as a team. So there's some information that might help you in those efforts within this packet of forms. Scrolling kind of quickly here to get through to the end. There is also a sample safe eating plan in this section, and this is something that you can use in your district. Again, you're welcome to make up your own forms, but we wanted to provide a sample, a template for you to consider. We have an emergency action plan sample, and your districts likely already have that in place. But here again is another example. We have a school meal modification worksheet. So this is something that you would work with your dietary and kitchen staff with in the district if you have certain needs for your student based on their medical condition or their diagnosis of pediatric feeding disorder. That sample for training feeders is in here. So as you train different people who will be feeding students, you can use a worksheet such as this to show when they've been trained and how they did with that training. And then we have a team procedure checklist. So this goes through all of those steps that we mentioned at the beginning. And this would be something that you could use as part of your IEP meetings to make sure that you're covering everything that we've talked about throughout the resource and the trainings related to PFT. And then in our appendix, there's one more form on identifying undernutrition and dehydration that's linked here. So that is the end of this resource, and that officially marks the end of this recording, and I will open it up for questions.